Hey everybody, this is Professor Butler, and I have here your endocrine slides. This is a very short presentation. We will go in depth a little bit more about DKA and type 1 diabetes care for children in class. So let's go ahead and get started. So let's see, these are your objectives and I'm looking at multiple screens, so please excuse me if I turn my head. These are your objectives for this lesson. And we're going to start off by going over a review for the endocrine system really quickly. Remember, the endocrine system is about hormones and feedback systems that actually stimulate and then signal for different organs, mostly in our neural system, to stop secreting those hormones. So the endocrine system controls and regulates metabolism, energy production, growth, fluid and electrolyte balance, our responses to stress, and then our sexual development. We already covered precocious puberty, so we will not be discussing that in this lesson. The endocrine system consists of many glands and the structures that secrete hormones, as I mentioned, and these are chemical messengers or messages that are delivered to specific target cells or organs. Cells and organs that receive these messages either produce another substance or they have a function on a particular system. Once that is completed, again, some will probably excrete or change in the level of the hormone, causing a feedback system that will tell the originating gland or structure to stop producing the hormone that is stimulating the message. Okay, so here are some of the most common glands, and I'm going to be very careful with my cursor because I know it's like all over the place sometimes. So here are the most common glands listed here on the right-hand side of your slide. We have here the hypothalamus, the pituitary, both the anterior and posterior pituitary, the thyroid, and these are starred because these are mostly the ones that kind of affect a lot of the pediatric population. Parathyroid, we really won't go much into it, but if you have issues with your parathyroid, then you're going to have issues with calcium, so somebody will really need to take a lot of calcium supplements. Adrenal cortex and medulla are important. We won't really cover that much in this lecture because it's not really that much different from adults. Pancreas, of course, because it's responsible for insulin, which we will talk about diabetes more in detail. And the sex glands we already talked about, but they are listed here as a reminder. Excuse me. So let's go to the next slide, which is just an illustration of kind of that feedback system that I was talking about. So you see the pituitary and the pituitary glands, the anterior and the posterior pituitary glands in the center of this slide, as you can see here, anterior and pituitary, and they receive stimuli from the hypothalamus. You can also see the portal pathway between the hypothalamus and the anterior and posterior pituitary, and there are just different things that can be signaled, as you can see here, the different hormones that act on the different organs and so forth. And it just is this is just a picture just to kind of give you an overview. It's always good to, if you're trying to figure out something, to have something to look at to see how the pathway or the process flows so that it makes sense. Similar to why I gave diagrams of the heart, why I gave diagrams of different things when it related to asthma. All right, so here's another example. If that first picture is a little bit too busy, here's another example of how things happen as far as this one specifically is regarding puberty. Again, we already went over that, so we're not going to go over into depth. And here's the last one, which talks about our fight or flight response from our stress hormones. So hypothalamus triggers the anterior pituitary gland. It releases cortisol and adrenaline. And then you have all these, and if I can move myself out of the way, You have all of these physical effects. And to be honest, I just want to stop for a moment because I think this is really important in healthcare, that a lot of studies have shown that this particular response system in our bodies has caused some physiological and psychological issues in healthcare providers. So when we're reacting to a code or trauma, or we are constantly seeing things that affect us internally, we have to have a way to process that, not just go home and then sleep it off and then go right back to it. We are actually causing some type of traumatic, kind of like PTSD. And it depends on where you're working. So people who are, and I would love to participate in a study like this in the future, but some people who are in some low-level traumatic things, they don't get exposed to abuse cases. They don't get exposed to gunshot wounds or MVAs and, near drowning. So those are the things that I kind of get exposed to. We realize over time, we don't really respond the same way we would normally respond, but that's not necessarily a good thing. So I'm just taking a little bit of moment on the soapbox just to let you know that what was missing that we needed to do, we needed to have a moment to be able to process it or have something attached to the fact that we are receiving trauma every day in some form if we are constantly in those environments. And a lot of people just didn't recognize it. They're just like, oh, I have tough skin. But, a lot of studies have shown. So just if you feel something, you need to just find a way to hopefully process it, balance it out a little bit so that the burnout and that emotional fatigue doesn't happen. All right, I'll get off my soapbox. Let's keep on going. So I gave you these last three just to kind of show you how the feedback system is. You'll have to review that. If this is not your strong point, please make sure that you review it. So keep moving on to our review. There are some things that you do need to know. For example, the pituitary gland is split into two lobes. Each is responsible for secreting different hormone secretions. The diagram on the right lists specifically which hormone that the gland secretes. But here's the thing. What I really want you to make sure you understand is that the anterior and the posterior have different causes. So let me see here. So causes to impair pituitary can be caused by either congenital, tumor related, or it could just be something that's idiopathic. Excuse me. I have a cough. Sorry. And as you can see, the anterior pituitary has many, many functions. This diagram goes into a lot of details, but if you have a loss or dysfunction to any of the anterior pituitary hormones, it is considered panhypopituitarism. I'll say it again. If you have a loss or dysfunction in the anterior pituitary gland, it is considered panhypopituitarism. Okay. So I'm going to move myself out of the way again. Sorry. So what I would like for you to just really emphasize is the one thing that I just told you. Okay. Kind of look at the fact that the anterior pituitary has the most functions, and you can see that if this is affected, we're going to have a lot of issues versus the posterior pituitary gland. If we have issues, we're going to have water balance problems, so fluid and electrolytes, and then we're also going to have uterine issues. But pretty much the anterior pituitary is very, very important. So now let's talk about some specific issues that we see in children. So panhypopituitarism, this tongue twister. Again, loss of anterior hormones. Hypopituitarism, common causes are basically undersecretion of hormones or short stature and growth failure. So let me go a little bit more detailed than that. So the one of the things that we see is we can see children who are growing at a rapid pace, and we can have children who are not growing effectively. Remember, we chart them on the growth charts. And if we see that there's a trend and a child is really below the curve or way above the curve, this is one area that we're going to investigate. So impaired growth after 1 year or so, if we see this on a growth plate like third percentile or less, and they continue to grow slowly, this could be a cause from the pituitary system. And again, there are a lot of causes, as I listed before. There could be tumors, there could be damage, dysfunction, some congenital issues. And so short stature or failure to grow could be because the pituitary gland is just under functioning. Hyperpituitarism is the opposite. Therefore, we have an excretion of more growth hormone, and therefore they're going to be very tall, or they're going to have a big kind of build to them. Anyhow, this is an overgrowth of long bones and muscles. So some of the signs that we see, of course, besides the charting of their growth, we also will see them develop much faster. And one of the things that we'll do is we'll do a bone age comparison. So if you take a look at these hands down here, you'll see the hand x-rays of somebody's hand. And this is also something that we do to kind of look at to see if a child has precocious puberty going on. So this is what a hand should look like for a 2-year-old, a 4-year-old, or a 7-year-old, and so forth. So when we do an x-ray of their hand, what we're looking at is their bone comparison. So if I'm taking an x-ray of a 7-year-old and they look like this, or they look like this, that means that their bone growth has accelerated and we could have a pituitary issue going on. This could be a cause, it could be a cause of thyroid issues, because a lot of the growth hormones and metabolism and everything is also associated with thyroid. We will also look at their sex hormones to see where they are on their level of sex hormones, both their estrogen and testosterone. All right, so I'm going to show you some pictures real quick. So this is what it looks like. So this is a normal face of a child. And then this is what it looks like when they have an overstimulation of growth hormone. Okay. We also kind of look at their other facial. This is a frontal look, and then this is a lateral look. Excuse me. Here's a picture of an actual girl who has we call it giantism, and you can see how her facial expressions look. And I think she might also have some congenital issues. I'm not 100% sure. But you can, because she has the eyes lined up, but you can see those that overgrowth of her muscles and her bones. Something's a little off. I thought I had another picture. I don't have another picture. And short stature is pretty straightforward. You know, children that are not growing, they're very short, they're not developing properly. So there's a couple things that we do need to do to rule out if a child has this, or if they have short stature or something's going with their pituitary. So some of those things would be like malnourishment. There could be some disease process that's going on that's causing it. There could be a genetic issue that the family is not really disclosing, or they may not be aware of, like dwarfism. There could be a growth delay with a child, so we may be jumping ahead and thinking that this child has this issue, but they just have a delay in their actual growth spurt. I told you about thyroid, and then there's a chemical called insulin growth factor protein, IFG1. And some children who have a high level of this protein in their system can also be reasons for their stunted growth, because it basically eats away at their metabolism. So we have to do the test, and the bone age is one of them, and to see if they, where they plot. We'll also look at growth charts, and then look at their trends, and then be able to then kind of come to a conclusion. Because if we do have a depletion or a low level growth hormone that is being stimulated, then they're going to have to take some injections. And basically, and I can move to the next slide real quickly. So basically, when we are looking at the pituitary system, it's either we're going to have to find a way to make the whole feedback system cut off so we're not having an overproduction, or we're going to have to supplement and give whatever hormone that's depletion, or we're going to have surgery, especially if there's a tumor that's affecting the area. We're going to have to go in and get that tumor and do some type of surgery. So we're either replacing, doing surgery, or we're doing some type of therapy to decrease it, or some type of combination of therapy. We have to have surgery and do hormone replacement. So like for myself, for example, my thyroid is gone. So they had to do surgery, and I take Synthroid every morning to replace, because the thyroid is no longer there. So I have to take medicine to replace the hormone. The nursing role is, basically we have to be very careful about our measurements. We have to have early detection and screening. We need to advocate sometimes for treatment instead of allowing people just to label kids. And then counseling is really involved. I mean, this is hormones can really mess up your system, and there's a lot of things that can happen. And I'll share in class, some of the things that I've come across. We have to make sure that we're very careful, especially dealing with children, because they may be going through different things, or things happening to their body that they just don't understand. And we may need to help counsel them or get them to counseling to get through whatever they need to get through, because it is a process. This isn't something you pop a pill and overnight you have results. It takes a long time to get people balanced. And then educational hormone therapy. So I want you to also make sure that you understand how we actually treat children with growth hormone replacement. Growth hormone replacement works during the first year of treatment, and most likely, their growth will come back to normal, but we have to catch it sooner. It is a sub-Q injection, and it's usually given at bedtime, because that's when our bodies actually release growth hormone when we sleep. A lot of stuff happens when we sleep. So we want to make sure parents know how to give it, and we also need to make sure that they know that they have to give it at nighttime. Okay, it is very expensive, and in fact, a lot of manufacturers. Okay, now we're going to talk about Graves' disease with mostly our neonates, but we also can see some issues in school-age children. As you know, as we talked about, the main role of thyroid is mainly metabolism. It also plays a huge role as far as growth for children. In this image that you can see here of this child, it is actually a 36-week-old newborn that was born with Graves' disease. This child was born IUGR due to the disease. The mother also had hypothyroidism, or hyperthyroidism, I think. And mom didn't know in this particular situation, because it did have a case study attached to it. The mom did not know she had it. A lot of times, thyroid disease is found in women when they actually go through pregnancy, because anybody who has thyroid disease, when they become pregnant, they have to usually double their amount of Synthroid or medication. But if you don't know, then this is what's going to happen to the child. And I can share with you anytime if you want to know my story. I didn't know, and my child came out very small. She didn't have protruding eyeballs or anything like that, but both of us, she's not diagnosed yet, I think, but I was diagnosed afterwards. Anyhow, Graves' disease is an autoimmune condition. As you know, the body makes antibodies and causes excess secretion of TSH. It could be due Hashimoto's, or they can have goiters, or it could be cancer related. So now what you can see with this, physically you can see the child has protruding eyeballs with a wide staring expression. And then there's the absence of wrinkles on the forehead when the child looks up. They also are going to have very low weight and weight loss due to the increased metabolism in utero. And they also will have an increase in heart rate. So let me just check. Remember, I'm going to look at two screens. So with children that are older, they will also have the weight issues, weight gain for hypo, weight loss for hyper. And we also will hear of some issues in school. So they'll have some behavioral issues. For newborns, we'll probably see a lot of irritability. That could be due to their glucose dropping considerably. And we also could see some seizures or questionable seizures. For school-age children, there could be attention issues, also irritability, inability to pay attention in class, and acting out because of the the neurological effect it has. You're unable to really control yourself, or you get very anxious very easily when your hormones are out of whack. So they can progress very slowly through school, have matriculation issues, and it can lead to a lot of problems. All right, so medication regimen. This can involve anti-thyroid drugs. As you know, these are the drugs that we use in adults as well. And these will basically decrease the amount of TSH that's being secreted and stimulating the thyroid. Now, beta blockers also do lower the heart rate, but they also decrease the levels of T3 and T4 in the system. So that's where propranolol, as you see here, is going to go ahead and help in both areas. One, control their heart rate, and as well control their hormone levels. Levothyroxine, once we have pretty much, we can remove it, or sometimes they go in with radiation and destroy the thyroid. Then we're going to have to put them on Synthroid once they're stable. All right. If a child, just want to make a note real quick, if a child is on an anti-thyroid medication, parents need to know that a major side effect for them could be leukopenia, which is a low white blood cell count. And so this can put them at risk for major infections. So in this case, if a child develops a sore throat or fever, we want to act on that pretty quickly. Then just saying, oh, let's just give them some fluids and wait for a little bit. No, we actually would probably want them to see a medical professional as soon as possible. Next, we're going to talk about juvenile hypothyroidism. As I mentioned before, it is also an issue for school age. They can have impaired growth and development. We also can see issues in skin and constipation, lethargy and mental fogginess, unable to concentrate. That's unable to concentrate in school. And then the issues with their classes. All right, next we're going to go to antidiuretic hormone. And we'll practice some of this in class because I don't know why. This one, for all healthcare providers, both learning and established, they get this SIADH and ADH, DI and SIADH and DI confused. And so here you're going to need to, get to know this particular system, because you're going to have to recognize the signs of whether a child is in DI or whether the child's in SIADH. So this first slide is just a reminder that, of the ADH hormone is a vasopressin. So basically when we give a vasopressin, we are constricting the vessels. We would give this in people who are possibly in shock. It regulates water in the body. The body normally secretes this hormone when one of the triggers, and there are different triggers that are listed below on the slide. So when one of these triggers come, it triggers the hypothalamus, which releases ADH in the body, and it acts on the kidneys to secrete the vasopressin. And so as you see here, the triggers are if there's a change in the blood concentration, so we get a very hypertonic situation, the blood osmolarity changes. We also, if we have a change in volume, so we have blood loss, or volume loss, or vice versa. Receptors in the cardiac system will sense that we have a decrease in volume, and then that whole process will begin. And then if there's changes in blood pressures, and those come from the baroreceptors located within the cardiac system. And when I say the cardiac system, it's not just the heart, but also baroreceptors are also located on our major vessels. So let's go to our next slide, which kind of breaks down some of the things differentiating between SIADH and DI. All right, so SIADH is the first one we see here. This is an overproduction. It's going to pause so you can see that. Creation of too much ADH, so you're going to have fluid retention. DI is an underproduction, and this could be nephrologic or basically renal, or be neurological. And this is a failure to secrete or create ADH. A common in the pediatric causes are brain injury, because there's damage to the hypothalamus. Tumors, again, damage or pressure within the brain that causes the hypothalamus to not act correctly. We can have a hypoxic injury at birth. That means a child did not get enough oxygen for an extended period of time during birth. Again, that causes brain trauma. And then pituitary and or hypothalamic lesions. So most of these are obviously neurogenic in relation. And these are some of the common things that we see that cause SIADH or DI. So here's a differential. So we have SIADH. Let me move myself out of the way so you can see. So SIADH is in the body and DI is in the potty. And so that's something that we use in the PICU all the time so that we get an understanding. It's very important that you know your sodium levels, because the main thing that we monitor or our PRN orders based on our vasopressin drip will be, hey, if your serum sodium comes back as this, then you need to go up on your drip or you need to go down on your drip. Okay. And the next slide, we'll talk a little bit more about nursing interventions. So these are the lab values that we typically will follow. In particular, your serum sodium that I'm circling right here, it's very important. And then I would also probably pay attention to your urine output. That's not on here, but it's going to be explained in just a second. And then we also will look at the blood osmolarity as well. So when we have a child who has this going on, we're going to get what we call serial sodiums. And so they'll have sodium levels taken every 2 hours. And when those sodiums come back, or the blood work comes back, then we will go ahead and we will adjust accordingly. So with SIADH, I said it's in the body. So we're going to have retention. So we're going to see bloating. And so that means you're not going to have a good urine output. So your urine output is going to be very poor. Then for DI, it's in the potty. That's a diuresing state. Your patient is going to be diuresing. You cannot keep up with this urine at all. When I have somebody in DI, which usually we have a lot of children in DI, I can't keep up with the urine. And so the next slide, and make sure you pay attention to these and know these. The next slide kind of breaks it down how we would manage this. And so for SIADH, we're going to have that weight gain. So we're going to have to closely monitor the weight. Our output is going to be decreased at below that 1 ml per kilo per hour. They're going to have mental status changes because our electrolytes are going to be affected. They're going to have headaches, possible seizures as a result. And whenever we also have that going on, they also feel nauseous. Remember, our vomiting center is in our brain. And then nursing management specifically for them, we're going to have to restrict fluids. We are going to monitor their Foleys on both sides, actually. Monitor their sodium. Expect to give diuretics, loop diuretics, because we need to pull off that fluid. We don't want to give them any fluid because they are edematous. And then we'll probably use a hypertonic solution and that would probably be something like a 3% sodium. For DI, and just remember, when you use a hypertonic solution, you're creating a hypertonic environment, and that causes, hopefully, if there's no damage to the kidneys, because if there's damage to the kidneys as a result, then it's not going to work. But that will cause fluid to come off of the patient. DI is diuresing, all right, diabetes insipidus. So they're going to be very thirsty. Why? Because all this fluid's coming off and they're dry. The urine output is going to be greater than 4 per kilo per hour. We have children that will literally grab the washcloth and just start sucking off of them. Like they just want something to drink because they're so thirsty. The urine will be very diluted. It basically look like water. They'll have signs of hypovolemic shock because they are becoming severely dehydrated. They're also going to have those mental changes because they're having electrolyte imbalance. Sorry, I had a little brain fart there. And then twitching. So twitching means that because of those electrolyte changes, you might have some twitching of the muscles, and they are also at risk for seizure activity as well. Nursing management, obviously we need to replace that volume, right? So they're probably going to be on normal maintenance fluids. They're probably going to get some boluses, and typically what will happen, we'll have them on maintenance fluids, and then depending on how much urine that they put out, we will have to give them a bolus of the same amount, 1-to-1 ratio. So I'll explain. So if they put out 400 cc's or 400 milliliters in the past 2 hours, and I have an order to replace 1-to-1, I'm going to give with 1-to-1 with normal saline, then I know over the next 2 hours, I'm going to have to replace that 400. So I'm maintaining them and then replacing whatever fluid that they're losing. We're going to monitor their sodiums as well, and then we're going to have a Foley in them. You cannot keep up with the amount of urine. And here we're going to give the vasopressin because remember we want to constrict, so we're trying to hold on to the fluid instead of it being dilated and falling through and getting through the system. So vasopressin is what we're going to give. The main one that we use is DDAVP. Make sure you know that one, and that usually is actually is the hormone replacement for the damaged hormone feedback system. And so remember, this is a lack of the hormone, and so that is why we have to replace it. And it works like clockwork. It's great, and within 20-30 minutes, if you give a student, Lord have mercy, if you give a patient DDAVP, we can give it sub-Q. And we can give it nasally because we teach the parents how to do this at home. Then literally within 20-30 minutes, you can see all the diuresing stop. All right. Make sure you know the difference between SIADH and DI. Next, we're going to go into diabetes. And just as a review, as I've done with the rest of them, make sure you understand the difference between glycogenolysis and glyconeogenesis. Tongue twister there. So glycogenolysis is a breakdown of glycogen to glucose, which is what normally happens, and it happens in the liver. And then glyconeogenesis is when we get glucose from protein and fat because we have depleted our stores of glycogen. So with children, I want to kind of focus a little bit on these 4 things down here. These are the particular events in their life that really impact their ability to be stressed, so to speak. So stress is psychological stress, stress and good stress and bad stress. It's like we all have. Also, their constant growth is a stress on their system, and that affects their glucose. If they're sick, or they develop some type of infection, that affects their glucose. And then when they are going through puberty, we'll see some changes in their metabolism and growth, production, and usage, and so forth. All right. Remember, glucose is needed throughout the body. It is the main source of energy in the brain. All right. And I already mentioned that liver is the primary storage and source for glucose, but it can be depleted. When it's depleted, then the body will pull from fat as well as protein, and it can break down muscle as an effect. So that's why sometimes when we get kids who are really uncontrolled type 1 and they're in a very bad DKA situation, we can literally see that they've actually lost muscle because of all the glyconeogenesis that is going on. All right, so let's go to our next slide. Just as another quick review, two major kinds, type 2 and type 1. We're specifically going to focus mostly on just type 1. We usually typically see this in a 10-year and younger. It's usually due to an autoimmune issue. Type 2, they used to call this juvenile diabetes, but it can happen at any age, and it's usually due to insulin resistance. Again, you can see if somebody has type 1, they will present with the starvation look on their face, or they'll be emaciated, and most of their energy is coming from protein and glucose, because remember, as I've always said, when I describe this, I love this picture that insulin is the key to the cells, to unlock the cells for glucose to be able to be used effectively throughout the body. But if insulin resistance is happening, or there's not enough, or whatever the case may be, that key doesn't unlock the cells, so glucose can't be used. So they have to go to the fat and the protein in order to be able to create energy. And that's why children have these high levels of glucose, but they look emaciated. They just look frail. They look horrible. Diagnosis, we can do an 8-hour fasting. Glucose levels, if they have repeatedly a fasting glucose, or really they said if they have a random glucose of 200 or more at any particular time, and usually they say 2 or more times, and that's a sign that we need to get these children screened. A glucose tolerance test of 200 or more, and an A1C of 6.5 or higher. Signs and symptoms that a child is in type 1 diabetes would be polyuria, glyceruria, and polydipsia. All right, so they're peeing a lot, they're spilling glucose in their urine, and they have excessive thirst. This is a little bit different than what you've learned in adults, but these are the 3 signs that you will need to know for this lesson. So we're going to talk... let me go to the next slide. So we're going to talk about how we treat and how you calculate. So here's a new calculation. You're going to have to know that our target range is anywhere between 60 to 120. And I will tell you that they change it all the time. Right now, we're going to use 60 to 120. We take their values throughout the day, and there's a whole process that we use to treat and manage diabetes in children. So there's 2 things that a doctor is going to have to order. They're going to have to order the correction formula and our insulin to carb ratio, as you can see. So here is our correction formula, and here is our insulin to carb ratio. So you're going to need these 2 things in order to be able to figure out how much insulin that your patient is going to need. All right, so let me see here. Let's talk about the correction formula first. So it's based off of the sensitivity factor, which is the amount of rapid acting insulin that will lower their blood glucose. And what we usually have is whatever their glucose is, and you then subtract that from their target, and then you end up getting this number. So I'll show you an example in just a second. And then our ratio is determined by the physician. It usually will read something like 1 unit of insulin per 10 grams of carb, or 1 unit of insulin per 15. All right, so they will specifically tell you what you need to cover for that patient, and it will base on their age, how they've been trending, whether they're greatly managed or not managed well. And so there's a lot of things that they have to take in consideration, but it's up to them. All right, so let me see. So let's go through the steps. So step 1 is you need to calculate the food insulin units. Step 2, calculate the correction units and then add them together. I think it's best. Let's just go through it. I think that's going to be best. So I'm actually going to jump ahead just a second and then I'll come back to 20. So here's what you're going to do. So you have a 4-year-old and they are ready to eat. So what you're going to do is go ahead and order the tray. Let them order their tray. And then you're going to, when the tray gets here, you need to go ahead and take their glucose. They don't get the tray yet. You take their glucose. There will be usually, and you guys have probably seen this, there will be a slip that will tell you how many carbs. And we teach the families when they go home how to count their carbs appropriately. And so you need to know how many carbs that's on the tray, and you need to know their blood glucose. Once you know what that is, then you can go ahead and let the child eat. We do not give them any insulin yet, but we have to let them eat first because children don't always eat all the food that's on their tray. Therefore, if we cover them with an expected amount of carb coverage, then that could be an issue when they don't eat, and then trying to get the child to eat after you've given them all this insulin. So the proper way, again, is to take their blood glucose before they eat. They take a slip or know what's on the tray, what's before them, and then they will let them go ahead and eat. Once they are finished eating, you then have to calculate. So let's just say this blood glucose for the child pre was 212. All right. And so what you're going to do is you're going to use and plug this in this, You're going to plug this into your correction formula. And so it's 212 minus 100 divided by 50, and you get 2.24. All right. So what you're going to do is that's going to be a 2.2 units. And you write that down. And then you're going to look at how much that they actually ate. And let's just say they ate everything here. Okay. So if everything was eaten, the total amount of carbs there listed is 87. And then the ratio that the doctor ordered was a 1-to-10 ratio. So you're going to divide 87 by 10, and that gives you 8.7. So 8.7. So you will end up getting a number of 10.9. So you're going to give 11 units of insulin. And the reason why we didn't do it to the 10th is because a lot of these insulin pens, and I can show you one if you want to see it, we don't have that small of units to be able to go to the 0.9. So we just go to 10. So we're not going to give them 10.5 because that may not cover them completely, but we will go to 11 because usually they have the half increments, but they don't have the 0.2 or 0.1 increments on the actual pen. So we're going to give 11 units. So I hope that you can see exactly what I just showed you. We're going to practice some more in class as well. So here's another one. So let's say the blood glucose is, I think I have it on here. Okay, blood glucose is right here. It says, let me go down real quick. Sorry. Blood glucose is 258, and you want to plug it into your problem right here. And then here is your 1-to-15 ratio. And in this particular one, let's just say the child ate chicken fingers, half of the tater tots, no peaches, and all the milk and no green beans. So in class, I want us to do this one together. Of course, you guys will probably figure out before we come together. But again, I'll say it again. The child ate all the chicken fingers, half of the tater tots, which will be 9 grams. They didn't want the peaches. They ate all of the milk, drank all the milk, and they had no green beans. So you'll have to figure out what is the total amount of carbs, and you'll have to divide that by 15, and then add both those numbers that you get down here, and then you'll have the total number of insulin that you're going to give the child. All right, so this will be resumed in a little bit. So slide 20 was just talking about how we look at labels. Always make sure that you look for the serving size when you're trying to figure out how many carbs. And we also are responsible, along with the nutritionist, in reminding or reinforcing the education on how to determine what your total carb grams are. So this is just an example of here. You have, some people might just look at, oh, it's just the sugar. No, we need to make sure that we look at the whole label and make sure that they are calculating it correctly. And also make sure that the serving size is appropriate for the amount that they're calculating. So watch serving sizes. Next, we're going to talk about, insulin injections. We already kind of just went over. I just want to mention that they do usually start off with a log, and the log will just be something so that we can kind of determine what their dietary intake normally is and how their glucose is responding, and if we need to go up on the insulin or down on insulin or adjust correction formulas and so forth. These are the areas that we give injections for our children. And pumps are highly needed. Anybody who is having Professor Warren as your instructor, you know that she's a diabetic. She's lived with diabetes for a long time. She has her pump right there on her abdomen, and she can talk to you about insulin pumps. There's so many insulin pumps out there. In the pediatric world, there are a lot of pumps that will signal the family member or a specific family member at work when it's getting too high or if it's getting too low, and they'll call them and say, hey, I just got a notification that my son's glucose is 40. Can you please check on him and make sure that he takes a glucose tablet? Or if he's just about to eat, that's great. But they notify parents when their child's at risk for passing out and being hypoglycemic, which is what we're going to talk about next. So hypoglycemia, I don't know if any of you guys have ever experienced this. I have experienced it, and that's mostly because I have thyroid issues. It was 100% connected to my thyroid. As soon as my thyroid was removed, I had no more hypoglycemic attacks at all. My insulin, maybe my insulin, but my sugars would drop dramatically. I could be walking around 20 and you guys wouldn't even know it. I became so used to doing that, and then all of a sudden I would hit a wall or do something and then I would pass out. So I'll have some funny stories about that. But moving on, all hypoglycemia should be treated with at least 15 grams of rapid acting carbohydrates. A lot of children carry around little glucose tabs. Other things we would say is, boxes of juices. We tell people to have little cartons of icing in their refrigerator, something they can easily access and put and rub on the inside of somebody's cheek. Also, glucose gel is good, but I will tell you that glucose gel can cause massive headaches, as well as the pen that you're about to see in a second. So what we usually, it's okay to just have some icing. The whole goal is to get them to become conscious and then eat something, and then that usually will fix the problem. If we have a child who has a low glucose, and right now, if you see something that's below 70, then we do need to act. Some of the signs and symptoms, they'll get confused, they'll get shaky. That's why low glucose in neonates is sometimes confused as a seizure. It can lead to seizure activity if it's not managed or treated, but usually they have a lot of shakes. They'll have palpitations. I love these pictures. They're so funny. They usually are very, what I call hangry, and they get mad. They have a temper. There's just so many different signs. Also, they can become very nauseous. That's something that I exhibited a lot, that I would all of a sudden have this wave of nausea over me. And then I knew, I'm like, but I didn't eat. And then I'm like, I got to eat something now. They're like, but you said you're nauseous. I'm like, it's not actually nausea. And I knew that if I didn't get something to eat, I was going to hit the floor. So don't wait, treat. If there's a child who has a low glucose, is acting that way, you check with AccuCheck. you check their glucose and it's low, then we need to do something. Depending on their age, depends on whether or not they're going to be as compliant. The older children obviously know, they can feel it. We have little kids that actually can come and it's like, I feel low. And they can feel it, and we can feel it in our bodies. I'm not a diabetic, but because I've had these happen to me, I know exactly what they're talking about. You can feel when you get low. And let me see here. So if they, and this is broken down with ages, and I think it shows on the next one, but if they're less than a year, we give them apple juice or 5 grams of glucose gel. If they're between ages of 1 and 3, we give them 2 ounces of apple juice or 10 grams of glucose gel. And then 3 years or older, you give them 4 ounces or 15 grams. You don't need to memorize that. You just need to know you need to treat it with either apple juice or glucose gel. And this obviously is if they are consciously able to protect their airway. If they are not able to do so, then you need to do the pen, or you give dextrose. If they have an IV, we can give them a bolus of dextrose. All right, so this is how it's broken down with their age, with their weight, excuse me. So the last one was about ages. This one's about weight. So we have to give them the emergency pen. This is what they carry with them in the event that they are unconscious and unable to actually take something in by mouth, so that they don't aspirate. So 0.5 milligrams for children weighing greater than 11 kilos, and then 0.25 milligrams for children weighing less than 11 kilos. You always want to treat them first before calling the physician, because you do have time, you have a limited amount of time before they start to seize. All right, they can go into a coma. Again, a side effect of glucagon, as well as the gel, is that they can get very nauseous, vomiting, and have massive headaches. Let me see here. And always after you do any type of intervention like this, you want to retest the blood sugar within 15 minutes. If the patient comes conscious, then we're going to go ahead and give them a quick acting carb or something more complex that they can tolerate. But however, if the glucose remains less than 70 after you've done your interventions, then we need to call because something's going on. All right, so now we are going to go into DKA. So this is our final topic, but it can be very confusing for a lot of students. I absolutely love treating DKAs. They can be challenging when you first work with them, but you have to understand what's going on physiologically in the body. And then once you get that, it's easy. This is defined with a blood glucose greater than 250 for a sustained period of time. We also will see that they are producing ketones in their urine. They will have metabolic acidosis going on. And we're going to usually see initially hyperkalemia, hyperphosphatemia, and hypernatremia. Hypernatremia is because the sodiums are going to be high because they're massively dehydrated, because this is a hypertonic state and they're going to be diuresing greatly. Hyperphosphatemia and kalemia are related, but that's usually because, in the beginning, but there is a little trick to that later on that we're going to talk about. Because what we call is a pseudo hyperkalemia, because there is an exchange of ions from one cell into the interstitial spaces. Excuse me. All right. So causes can vary, and why they go into DKA. A lot of it has to do with the initial things I showed you on the slide. Sometimes they have an infection going on. Puberty is a big cause, and then new onset. They finally are manifesting in a way that they present in DKA to the hospital, and that's usually that's one of the major things that we see. So new onset, infection, and puberty are usually the causes. All right. Pump malfunction can happen. Actually, Professor Warren had that happen to her one time. So they can go into DKA. Another thing I have listed here is drug or alcohol use. If they start experimenting with things that their parents may not know, smoking as well. And some students actually know that they can actually lose weight and go into ketogenesis, and some people get their hands on insulin and they use it for weight loss or control, and guess what they cause? Yeah. Yeah, it's interesting. All right, and so a review here, some of the signs and symptoms that you'll see, and I do believe you know about DKA. I hope. Hyperglycemia, this is what we see. I've kind of talked about that already. Some of this is just a repeat. Polyuria, polydipsia, nocturia, that it can happen, but remember what I said is the third one for peds. Not going to tell you, go back to the slide. Dehydration, I'll say glucose, and you'll understand, you'll remember. Dehydration, lethargy, weight loss, body pain, muscle cramps. That's because of all that electrolyte imbalance and all that potassium issues, as well as calcium and phosphorus and sodium. There'll be an acidosis. So that Kussmaul breathing, what they're trying to do is blow off that extra CO2. So that's why, and it smells fruity when they do that. And that vasoconstriction, if they do have vasoconstriction, they're very sick. All right. There is also, just want to say real quickly, there is a video that I posted. It's a very quick video, but it does a great job of reviewing DKA. So take a look at that a few times. And if you need some information on or reminder on Kussmaul breathing and all the chemistry, I do have that. I can send it to you. But basically, they're blowing off CO2 and it's a compensatory mechanism. All right, so here we go. I just realized I didn't change the slide. So this is a slide that I was looking at, guys. I'm so sorry. All right, now we're on the same thing. So that's the video. I think that there is a link, but I know I posted it on Canvas, so you should be good. All right, how do we treat this? So strict NPO. They're going to be diuresing, similar to DI. They're going to be wanting to grab that, grab that washcloth. If you give them a little, the sponges, so they can clean their mouth, because their mouth is going to be so dry because they're dehydrated. They will actually suck on that a lot. So you make sure, be careful about how much water you put on that. They're not allowed to have food or water. We have to take over and get them stabilized. So the first thing we're going to do is we're going to start a rehydration process. And they're going to get bolus because they are severely dehydrated. So we want to make sure that they don't go into hypovolemic shock. And then we're definitely going to get a full panel of electrolytes as well as a blood gas, and see where they are with their acidosis. And we're going to see where they are with their electrolytes, the renal function as well. And then we're going to get their sugar. And we'll see where they are and how fast and what we need to do. So we start off with normal saline, isotonic solution. We do not add any additives until we get our electrolytes back. Once we get our electrolytes back, we say, oh, okay, we'll probably see some elevated sodium and potassium for sure. Once you start the insulin drip, then we have to do another and probably about in an hour, we do another round of electrolytes and blood gases. And then you will see the potassium drop. And that is when they will start to get a massive amount of potassium. Electrolyte replacement of potassium is added after getting the initial electrolytes, and then after the insulin drip starts. Insulin drips are 0.1 units per kilogram per hour. And that will cause the glucose to move into the cells and stop the breakdown of protein and fats, and that whole ketogenesis is happening. I'll say it again. So the first thing you're going to do is you're going to give a rehydration to avoid the hypovolemic shock. We're going to get a full panel of all of the electrolytes. They're going to be put on a monitor. They go to the ICU. This is an ICU situation, depending on how high their sugars are. Then we do not give them any initial potassium in their fluids, even though we know they actually have a pseudo hyperkalemia, because potassium has moved out of the cells into the tissues. Into the bloodstream, tissues, bloodstream. Once we start insulin, the potassium moves back into the cells, and they will be massively hypokalemic. Then we are going to start to give them lots of potassium in their fluids. Potassium replacement is completed once insulin administration begins. And then another big thing, and then what we're going to end up doing is we're going to be rehydrating them, doing their electrolyte balance, fixing their acidosis at the same time, and then monitoring and controlling the decrease of their blood glucose. We do not want our patients to have we do not want them to have a greater than 100 drop an hour of their glucose, because that can cause cerebral edema. Okay. Now, if they do, then we're going to end up putting glucose back into their fluids to offset the drop that they're having in their glucose. Because if we have a massive drop, or we give them a massive amount of insulin at one time and just shift and do a massive shift in their osmolarity, then that can cause cerebral edema and they'll die. And I've seen a few people do that too. By the time the child got to us, first they went to an adult hospital, which was the nearest hospital, and they were then transferring to a pediatric hospital, and they treated the child like an adult. And they gave them massive, they saw the blood glucose of 450, and they're like, let's give 20 units of insulin. Let's get this glucose down. So they gave 20 units of insulin, and they caused a major shift in osmolarity, and the kid died. So we have to do a controlled decrease of their glucose over time. And we do that by the insulin drip, which is a standardized drip that you see there. But if we see that they're dropping too fast, then we need to put glucose back into their fluids. So the fluids that they're getting is like a 3-bag system. So we'll have a bag for the rehydration. We have a bag, an IV specifically just for our insulin drip, because you don't mix that with an insulin drip with anything else. And then you have your bag where you have your electrolytes. So your rehydration, your insulin, and your electrolytes, or we don't put dextrose in it until we need to. And then your potassium, whatever their labs come back, we know how much we have to put in there and give them. And we change these bags often based upon whatever their electrolytes come back, because how I talked about serial sodiums for our DI and SIDH, we are going to be getting glucoses every hour. We're going to be getting vital signs, watching their cardiac rhythms, because we're giving a boatload of potassium. And we're going to be looking at their gases every 2 hours, their electrolytes every hour, every 2 hours, and we're going to be monitoring for that cerebral edema. Okay. So, excuse me. So there's a lot going on. Rehydration, electrolyte reimbalance, dealing with our glucose, insulin drip, monitoring all that. They are a one-to-one patient. These patients, literally, you're set up in the room. You are pulling off, doing things, changing bags, doing this, doing it, rechecking, doing constantly. You don't have time for another patient. So I mentioned that we put glucose in if they're dropping too fast. Once they hit the glucose level of 250, then we automatically have to put glucose into their bags. All right. Usually at this time, we're not rehydrating them anymore. We just have our normal maintenance bag, and we still have our insulin drip going. Okay. And then at some point when they get to a certain level, the endocrinologist will say, okay, order a tray. So they order a tray because we're going to transition them back to injections. So they'll say order a tray, and then once the tray is here, stop the insulin drip, give long acting. They'll have all these orders, let them eat. and then they'll get transitioned and get transferred out. And so it's a guided process, and it's a little different for everybody, but basically it's usually the same. Order a tray. When the tray's here, turn off the insulin drip, take their glucose, give them a long acting, and then if they're already established patient, give them a specific injection, let them eat, and then get them to the other floor. Okay, so that's a lot. Please let me know if you have any questions about that. I think your book does a really good job of explaining why we do certain things. You are going to need to know exactly all that's going on. 3-bag system. What are we doing with each bag? When do we put potassium? What is our sodiums going to be looking like? We're going to be doing blood gases. They're going to be acidotic. Some of the signs and symptoms. All of those things you're going to have to know. So the last thing I have here is really just the team that really works with patients who are new onset or coming back in DKA again. And the RN basically does a lot of these different things, but we are really reinforcing a lot of the teaching that you see the certified diabetes educators, which could be a nurse, dietitians, social workers, physical therapists get involved because they have to learn how to manage their activity or learn the signs of activity, especially if they're in sports. And they'll talk a little bit more about how they manage their condition while they are playing in certain sports. And then child life comes in, of course, helping them to adjust to this whole new world of managing a chronic illness. And so all of these, as well as the physician, of course, are all going to be involved in caring for this child, not only in the hospital, but they have diabetic clinics for children. So when they go to the clinic, they all will go kind of walk through and just, seeing, hey, how's things going? A social worker will come in if they're having issues getting their supplies, transitioning to caring for themselves, because there's a point where we want the child to learn how to just care for themselves, physical therapists and child life, etc. Y'all get the point. All right, so I think this concludes this. We'll talk a little bit more. We'll practice some calculations in class. I know you're going to probably want me to talk about DKA again, so if you have any questions, please shoot them to me. And other than that, make sure you know about SIADH, and the rest of this was a lot of review. Okay. All right. Thank you.